Good morning, everybody. We are starting chapter 20 with the heart. In this text, we actually divide the cardiovascular system into three different chapters. The last chapter we did was on the blood, chapter 19. 20 is on the heart, and then chapter 21 will be covering blood vessels. So when you look at the cardiovascular system, remember we have divided it into three different chapters because of the amount of the material. As we start to look at the heart, we look at the two primary circuits in the body, and that is the pulmonary circuit and the systemic circuit. The pulmonary circuit is really for carrying blood that does not have oxygen to the lungs to get rid of carbon dioxide or waste and to bring oxygen back into the heart to go to the rest of the body. The systemic circuit is going to pump blood to the pulmonary circuit as well as the rest of the body after it gets oxygenated. So this is important to understand the difference between the two pulmonary circuits. When we look at the pulmonary circuits, the pulmonary arteries and pulmonary veins are reversed as to what we usually think of. Arteries, we think oxygenated blood, red, and veins, we think of deoxygenated blood and blue. However, that is flipped for pulmonary arteries and umbilical arteries actually, and pulmonary veins and umbilical veins. So they are reversed. So you see the pulmonary arteries here are blue because arteries always carry blood to and from the rest of the body. So the arteries are carrying blood away from the heart to the lungs, but it's deoxygenated. The veins are always going to carry blood back to the heart. However, in this case, the veins are carrying oxygenated blood back to the heart from the lungs. One of the major pathways that you need to learn in anatomy and physiology is the blood flow through the heart. This is very important. It's typed out in your lecture notes. You need to know the pathway through the heart, including the valve. So please look at your lecture notes and make sure you know this for your next learning activity. Hint, hint, it'll be on your next learning activity. Do I need to be any more clear? One thing that people get a little bit confused of is the bicuspid valve. It is also considered the mitral valve. Either one is correct. You almost never hear the bicuspid valve. If you have a defect, for instance, it would be a mitral valve defect. They would not say bicuspid. So either one is correct. I would not take off for that, but please know your pathway. Going all the way back to the first chapter of Bio 205 when we learned our body cavities, here we can see that the heart sits in the mediastinum, and the mediastinum is in between the two pleural cavities holding the lungs. It's important to note here that the base of the heart is actually the top or the superior part of the heart, where the apex of the heart is the bottom. Usually we think of the base as the bottom, so in this case it is not at the bottom, it is at the top. And this is where your great vessels actually connect in. You can see the aorta there, and the superior vena cava are connecting into the base of the heart. So please remember base from apex. The average size of your heart is about 14 centimeters long and about 9 centimeters wide. Generally speaking, we look at the heart to be about the size of a person's fist, and it's the person's fist that relates to their own heart. So of course your heart is going to be different than someone else's heart. If you had to describe where your heart was in scientific terms, and I love asking this question, by the way. I want to know that you remember all of your regions and scientific terms from way back in 205. So, of course, we look at the base of the heart here and the apex of the heart. The heart is posterior to the sternum, medial to the lung, anterior to the vertebral column, and the base lies at about the second rib, and the apex lies at about the fifth intercostal space. It also rests right on top of the diaphragm. So if you were to come in and give terms, we already know it's in the mediastinum within the thoracic cage. You could list many ways you could think of many ways to describe where the heart is in reference to other parts of the body. You can see the dominant landmarks here on the superficial part of the heart, and of course this is an anterior view. It's important, and I know we're not dissecting the heart in lab, but if you could watch the dissection, that's very handy, because you have to know what side of the heart you're looking at in order to identify different parts of it. So here you can see the right atrium, right ventricle, the left atrium, the left ventricle. You can see the auricles of the right and left atriums. You can see the interventricular sulcus, the fat within the vessels of the coronary sulcus, the aorta, the ascending aorta, the superior vena cava, the pulmonary trunk. Just take a look at this and start to familiarize yourself with the parts of the heart and where they are. And always remember, when you are assessing a patient, it's their anatomical position that you're looking at. So your right is not their right, okay? So as we're looking at this slide, you'll notice that the right atrium, the right side of the heart, is in the anatomical position. Here we can see the wall of the heart as well as the coverings of the heart. So the heart is covered by the pericardium, and the pericardium is actually subdivided into a fibrous pericardium, which is the outermost layer, and it surrounds the visceral and parietal pericardium, otherwise known as the serous pericardium. Now, if you'll remember, the serous membranes are divided into visceral, which covers the actual organ itself, and the parietal, which lines the pericardial cavity. So remember, visceral and parietal. And then we get into the wall of the heart and the layers of the heart. And I don't want to confuse you here, but the visceral pericardium is also known as the epicardium of the wall of the heart. So it has two names. It can be considered the outside layer, the outermost layer of the wall, and be called the epicardium, or it can be called the visceral pericardium. So both names are absolutely correct. Then you have the myocardium, and this comprises the vast majority of the wall of the heart. And myo, of course, is muscle, so that's all of your heart muscle. And then finally we get the innermost layer of the heart called the endocardium, and it forms the inner lining of all the chambers of the heart, and it's a relatively thin layer. So notice the epicardium and the endocardium are both quite thin, and the myocardium is very thick, the thickest layer. If we take a look at the heart wall, a little bit closer look at the musculature, you have atrial musculature that actually forms a band around just the atria, and then you have the ventricular musculature, and this actually forms like a spiral band around the ventricles. And the reason this is important is because of the contraction of the heart. So if you can kind of think about wringing out a washcloth, think about that contraction. It's contracting around the ventricles, and then it's contracting around the atria. So the musculature is quite important. The skeleton of the heart is actually, it's a fibrous connective tissue that surrounds the origins of the pulmonary trunk and the aorta, as well as the orifices between the atria and the ventricles. So the fibrous skeleton actually provides an attachment for all the heart valves as well as the muscle fibers. So that's very important, because otherwise where would they attach to? The skeleton of the heart is also important because it prevents excess dilation of the heart chambers during contraction. So they cannot open up too far. It's going to actually constrict the dilation. And the rings and the masses within the interventricular septum make up this fibrous skeleton. So it's important to understand that this has a key role in the structure of the heart. The atria and ventricles are separated by muscles called septa or septums. And so you have the interatrial dividing the atria, and then you have the interventricular septum dividing the ventricles. Notice that the interatrial is quite thin, and the interventricular septum is quite thick, dividing that out. Here's a good chance to look at the right atrium. Of course, this is going to receive the blood from the rest of the body through the inferior and superior vena cava. And at this point, if you look at right where the arrow is pointing on the interatrial septum, this would be where we have something called the foramen ovale. And before birth, that's an opening within the atrial septum. And it actually connects the two atria of the fetal heart because the blood flow in the fetal heart is quite different. Now, this closes after birth and forms actually the fossa ovalis. So that's just an important note to remember. If we go down through the, if we're leaving the right atrium, we have to go through the tricuspid valve, and you can see that at the bottom going through, there's a hole there, and that would be your tricuspid valve. Now, one other thing to note in the right atrium are the pectinate muscles, and these are muscular ridges, so I don't know how well you can see them, but these are muscular ridges that are on the anterior atrial wall, and then again on the surface of the auricle of the atria. As we leave the right atrium to go into the right ventricle, we have to pass through the tricuspid valve. So if you can see on the right side, the top left is the tricuspid valve, and it has three cusps. Obviously, that's why it's called tricuspid, and you can kind of see those openings there. And if you look at the other side of the slide, what you can see here is the right atrium and the cusp of the tricuspid valve. You also want to notice that the valve is attached to what are called chordinae tendineae from the papillary muscles of the ventricle. And what these do is prevent the valve from opening backwards. So we want the blood to go in one direction and one direction only. We do not want that to be able to open back up and blood go from the ventricle backwards into the atria. So this is important, and you should remember the chordinae tendineae are attached to the three edges of the valve and from the papillary muscles, and this prevents the valve from opening backward into the atria. If we look at the other side of this slide, back over to the right-hand side, we can see the top left is the mitral or bicuspid valve. And then in the very middle is the aortic valve. The very middle is the aortic valve. The bottom is the pulmonary valve. So if you were shown a picture, you should be able to identify these. So the top one, you can see the three slits there. That is the tricuspid. Right next to that on the other side is the mitral valve or bicuspid. Smack in the middle is the aortic valve. And then right at the bottom, middle, is the pulmonary valve. You should be able to identify all of these valves. Very important. A couple of things to make note here. So we've gone from the right atrium through the tricuspid valve into the right ventricle. Now, notice the right ventricle from the left ventricle. The right ventricle is only receiving blood from the right atrium, and it's going to pump into the lung. So it's going to go through the pulmonary circuit from the right ventricle. Now, this is important because it has a much thinner wall than the left ventricle. This is because the left ventricle is going to pump blood to the entire body. The right ventricle is only pumping it to the lung. So that is a big difference in the wall thickness, right versus left ventricle. The other thing you can see here, if you look inside, are what are called trabeculae carneae. And the trabeculae, if you think about our spongy bone has trabeculae, well, in this case, the trabeculae carneae are muscular ridges on the internal surface, and these are on the internal surfaces of the ventricle. So you can see the right and left ventricle have the trabeculae carneae. So make note of the wall thickness in the left ventricle is much thicker than the right ventricle, and that has to do with where the blood is going. Okay? Also make note of the trabeculae carneae in the ventricles only. I love this view of the heart. It's a transverse section, so it's just, if you cut the heart in half and you opened it up, then you could see down on the inside. So this would be like cutting between the atria and the ventricles. So if you look, you can see the top of the tricuspid valve, and it's open, so blood is going from the right atria, or right atrium as singular, atria is plural, the right atrium down through the tricuspid valve, which is also called the atrioventricular valve, or AV valve. It goes down into the right ventricle. Now, at the superior end of the right ventricle, you have the pulmonary valve, and this is a semilunar valve as opposed to the atrioventricular valve, and it leads into the pulmonary trunk. Okay, and so then it divides into the left and right pulmonary arteries eventually once you get there. Now, as blood is coming back into the heart, it comes into the left atrium, and this is delivered back through the pulmonary veins, is going to deliver that oxygenated blood, and it's going to come into the left atrium, and it has to go through the mitral valve to get into the left ventricle. And remember, what's different about the left ventricle? The walls are much thicker here. And if you look at how does the blood leave the left ventricle, that is through the aortic valve. So the aortic valve is another semilunar valve. So you have two AV, or atrioventricular valves. Those are your cuspid, mitral valve, or bicuspid, and your tricuspid. And then you have your semilunar valves, which are your aortic valve and your pulmonary valve. Now, important to remember, your aortic valve and your pulmonary valve are going to the circuit. Okay? The cuspid valves are going between the atrium and the ventricles. The semilunar valves are going to the circuit. So the pulmonary valve is going to the pulmonary circuit. The aortic valve is going to the systemic circuit. So please make note of that. If you were to compare the left and right ventricle, this would be a great comparison question. The right ventricle is much thinner than the left ventricle because it has a different job. The right ventricle is under less pressure than the left ventricle, and the right ventricle is more of a pouch than the left ventricle, which is more rounded. So things to make note of is if you had to do a compare and contrast question. Instead of a transverse section, we're going to look at a frontal section now. So this would be taking and dividing the heart into front and back. Here you can see the mitral valve opens up as the blood comes in from the lungs through the left atrium, down through the mitral valve into the left ventricle. Okay, so I'm trying to speak clearly because I'm scared that I'm going to misspeak, and so if you're wondering why I'm really enunciating, left atrium into the left ventricle. And notice at this point that the aortic valve is closed until you have a contraction and apply pressure. That's when the blood will leave the left ventricle through the aortic valve. Now, remember what valves are for. And I put this in your lecture notes, but it's always important to remember, valves are always to prevent backflow. So whatever valve you're looking at, you have to understand where it's going to. So if I was to ask you, what does the mitral valve do? You would say the mitral valve prevents blood from flowing from the left ventricle back into the left atrium. That would be your answer. If I was to ask the aortic valve, you would say the aortic valve prevents backflow of blood from the aorta back into the left ventricle. So make sure you know where those valves are and what they're doing. They're always going to be preventing backflow. Very, very important. Valves prevent backflow, as we know, and sometimes we have to understand, when do the valves open? So if the ventricles are contracting, that is when the semilunar valves open. If the atrium are contracting, that is when the AV valves open. So it's important to understand when the valves are closed and when the valves are open, because it makes a difference. You cannot have them open at the exact same time. You have to have the tricuspid valves closed, then that means the aortic valve and the pulmonary valve or semilunar valve are open, and vice versa. If the tricuspid and the mitral valves are open, then the aortic valve and pulmonary valve have to be closed. And that's how it works. So depending on what part of the heart is contracting at any given time will determine what valves are open at any given time. Now, I want to point out here that if we get into a situation where we have a problem where a valve does not close completely, we might call this a mitral valve prolapse. You've heard that before. And sometimes you'll get into a situation where you can hear what is called a murmur, and what's happening is you're hearing the valve's not closing completely, and you're hearing a little bit of blood flow going back into the atria. So if you have a heart murmur, that means your valves are not closing completely. Sometimes this is not a problem, sometimes it's more of a problem, it just depends. A little bit different view here. When the ventricles are contracting, that is forcing the aortic valve to open, but look at the mitral valve, has to be closed. Look at the chordinae tendineae here. They are tense. They are holding onto those flaps to keep that valve closed. The papillary muscles, are contracted, and the left ventricle is contracted, and that is forcing the blood out of the aortic valve into the aorta, which is going to go out to the entire body. We've talked about the pulmonary circuit, and we've talked about the systemic circuit, but what we haven't talked about is how the heart itself gets blood. So as we look at this, we have to understand that it has its own blood vessels, its own blood supply that is actually not part of the systemic circuit or the pulmonary circuit. So the first thing we see is the left and right coronary arteries are going to come right off of the aortic valve. So the aortic valve is going out the aorta to the systemic circuit, but coming off of that, you have the right and left coronary arteries. So it's coming right off of that valve before it gets to the aorta itself. Now, when you look at this, you have to understand that the right coronary artery supplies blood to the right atrium, portions of both ventricles, and to portions of the electrical conducting system of the heart. And it gives rise to other arteries. I'm not so concerned that you know those. I just want you to understand that it gives rise to other arteries. The left coronary artery is going to supply the left ventricle, the left atrium, as well as the interventricular septum. And it is going to give rise to two other arteries called the circumflex and the anterior interventricular artery. So if you look at the left and right arteries and what they branch off to, you'll notice that the right coronary artery branches to the posterior interventricular artery, while the left branches off to the anterior interventricular artery. So understand that you have blood supply to the heart. It comes off the aortic valve, and the right and left coronary arteries supply different parts of the heart. This summarizes the blood supply to the heart, looking at the right coronary artery versus the left coronary artery. It's also important to understand that there are arterial anastomoses, and what these do is they are actually going to connect the anterior and posterior interventricular arteries. And this enables the heart to have a constant blood supply, And this is really important because the heart doesn't do so well if blood supply is cut off. Okay, and we'll talk about that in a little bit. As we look at this anterior view of the heart, we can see the coronary vessels that we mentioned before. Please notice you have a great cardiac vein. It runs right alongside the anterior interventricular artery. This is important because the great cardiac vein is going to actually return blood to what is called the coronary sinus, and the coronary sinus opens directly into the right atrium. The rest of the veins are actually going to empty into the coronary sinus as well, and then the anterior cardiac veins are going to empty into the right atrium. So everything from this circuit is still going to empty into the right atrium, just like the systemic circuit does to the rest of the body. Here we can see in the posterior view that you have the posterior interventricular artery, and you can see a really great shot of the left ventricle here. Notice the coronary sinus. So the coronary vessels are going to drain into that coronary sinus, which is going to drain into the right atrium. So remember, everything is going to, all the cardiac veins are going to drain into the coronary sinus, which are going to drain into the right atrium. That's important to understand. You don't have to know every single vessel within the coronary vessels, within that grouping of coronary vessels, but you do have to understand where they drain to. That's important. This is the view of a real heart, and we're looking at the posterior side of it. We actually have a colored, colored latex has been inserted into the vessels so that you can see them much more clearly. Actually a really cool view to see. Look at that great cardiac vein, which is going to turn right into and drain into the coronary sinus, and that of course goes into the right atrium. Here you can see the inferior vena cava going right into the right atrium, and then you can see the superior vena cava. You can also see the pulmonary veins that are going to go into the left atrium, and you can see the right and left pulmonary veins there. Look at how big those are. So those are delivering that oxygenated blood. You can also see the left pulmonary artery leaving and the right pulmonary artery leaving to go into the pulmonary circuit. So this is a great view that you can see the vessels just really clearly here. If we're going to talk about coronary arteries, coronary blood supply, we have to talk about CAD, coronary artery disease. And the reason I bring it up and I talk about it and I really stress the importance of it is because it's the leading killer in the United States of America. It leads to 500,000 to 700,000 deaths every year. So 500,000 to 700,000 deaths every year from coronary artery disease. 1/3 of all deaths in people over the age of 35 are from coronary artery disease. Think about that for a minute. That is a lot of people. We're worried about viruses. We should be worried about coronary artery disease. How do we prevent this if we really want to stop people from dying? Because this is your big killer. Okay? Usually we look at a blockage to a coronary artery. This is from plaques or atherosclerosis. These fatty plaques or deposits build up and they start to block the circulation within the coronary arteries. What this does is it prevents oxygen from getting to the heart, which we absolutely have to have. And once we reduce the oxygen, we reduce the efficiency or cardiac performance. So this is key to your survival. We do not want coronary artery disease. This is a comparison of a normal artery versus the narrowing of the artery. And you can see that lumen, that vessel is wide open in a normal artery, but as soon as you start developing these plaques, these atherosclerotic plaques, you start closing off that artery, and you can see that you're not going to get blood supply as well through an artery that's narrowing. And this narrowing, as soon as this starts building up, the buildup never really stops unless you do something lifestyle related to reverse the narrowing of this artery. And believe it or not, lifestyle changes can reverse this process. So don't let anybody tell you that it can't. Do your research. It can be reversed. So a few things that we're going to look at as we look at this subtraction angiography. You can see where the blockages actually are, especially in advanced CAD. When you look at coronary artery disease, there's a couple things that start to happen before you get into the full-blown disease. You can have a couple of symptoms. One is called ischemia. So coronary ischemia is when you have reduced circulatory supply because of a blockage in the artery. That can lead to what is called angina, or usually we call it angina or angina pectoris. This is usually one of the very first symptoms that we have, and so it's a temporary ischemia, and it causes the heart to increase its workload, and you may feel comfortable when you're sitting down, resting, sleeping, but as soon as you start getting active, or moving around a lot, or in a stressful situation, you can get a lot of pain. You can get the typical heart attack symptoms, actually: pressure in the chest, constriction, as well as pain radiating either down the sternal area, in your arms, or your back. So you're not having a full-blown heart attack at this point, but it sure can feel like it when you get into angina. Now, if you get into a full-blown MI, myocardial, so that's the heart muscle, infarction, this is what we know as an MI, or a heart attack. And so the coronary circulation is blocked, so we've been studying the coronary vessels, and when that happens, you lose oxygen, your cardiac muscle cells start to die, and this is known as an infarct. And it really commonly occurs when you have an advanced CAD, like shown in the heart here. So notice that you can't see half the heart here because of the blockages. So the blood flow has been restricted in that ventricular myocardium, and you can't even see it because it's not getting the blood supply. So the blockages may lead to the heart attack. What do we consider a severe versus a non-severe heart attack? Well, if you die, it was very severe. If you don't, it wasn't as severe. And I don't mean to make light of it, but it's really true when we start talking about myocardial infarction. Because about 25% of all people, their very first time they have an MI, die right on the spot before they can get medical attention. 65% of the deaths, of MI deaths, are actually people under the age of 50, and they occur within an hour. So think about that. Under the age of 50, 65% of people who have an MI will die within the first hour. Those are some pretty scary statistics, I think. Just saying. That scares me a little bit. Sometimes you could have a heart attack and you either deny it or you don't really know what's going on. So it may not be like this clutching of the heart where you clutch your heart and you fall over, fall to the ground, or this pain radiating. A lot of people, women especially, have different symptoms than men do, and they may just ignore it. They may just be like, I don't know, I'm not feeling that great today. You just might feel off. It might not even be anything distinct, and that's why sometimes it goes undiagnosed. More in women than men, but women are catching up. So we are going through the same stresses in the workplace as men have traditionally done, and therefore our heart attack rates are going up as well. So we can have signs that we have clogged arteries within our body, and the first sign might be a heart attack or a stroke. A stroke is going to block the carotid arteries leading to the brain, so this isn't CAD so much, but how do you know if you have clogged arteries in general? Maybe those arteries aren't just going to the heart. If you have clogged arteries they are everywhere in your body. You just don't have clogged arteries in the coronary arteries. So you can have the carotid artery leading to the brain. What are some symptoms? Fatigue and dizziness. What if you're always tired? Well, you may be tired because you don't have proper blood flow. If you don't have proper blood flow, then you can get dizzy. We see this more in women. Shortness of breath, that makes sense because you don't have the blood flow, you're not getting the oxygen. If you're not getting the oxygen, it's harder to breathe. You can have chest pain. Sometimes you do, sometimes you don't. Chest pain, of course, is known as angina. And this could be maybe not full-blown pain. It might be numbness. It might be a burning sensation. It all depends. You could actually have lower back pain, which is interesting because a lot of times you don't think of lower back pain with clogged arteries. You think of the heart, you don't think lower back pain. Here's an interesting one, ED. So a lot of people, you can't turn on the radio without hearing about ED and, medications for ED. Well, what they really should be looking at is what's causing the ED, and that is coronary vascular or coronary artery disease or just coronary vascular disease, atherosclerosis. It doesn't matter where it's at, it's in the body, so it would make sense that blood flow to the genitals is going to be cut off as well. It can be cut off anywhere, the brain, the heart, the genitals. You can have painful, numb, or cold hands and feet. This means that you have plaques in the arteries that are leading to the arms and the legs. So that can, I always have cold hands and feet, so I'm kind of concerned, but hopefully I'm not suffering from this. But, you look at these symptoms, does this mean you have cardiovascular disease? Not necessarily. These are just some of the warning signs. So we know some of the signs and symptoms or signs, I should say, of coronary artery disease. The thing is that we don't want it to lead to a heart attack, or we don't want it to lead to a stroke, okay? So coronary artery disease, of course, is just dealing with the heart, but in the last slide I show you it doesn't just have to be the heart. It can be other places in the body. On this slide, it says it kills about 370,000 people annually. So this slide is a little bit outdated from the numbers I gave you before. So the numbers are all over the place, 370,000, 500,000, 700,000. There's, you know how it is with numbers. It depends on the source. So there's a couple sources here. Don't get hung up on that. Just know that it is the leading killer in the United States. So we don't want coronary artery disease. How do we prevent it, or how do we treat it? So we can prevent it by never smoking, having a healthy lifestyle that includes eating well, exercising regularly, getting yourself to a healthy body weight. So if you know you need to lose weight, you should get to the healthy weight so that you do not have to worry about getting cardiovascular disease or CAD, coronary artery disease. So we can prevent it, but what if we already have it? So we're thinking, oh my gosh, what if I already have it? Well, you can treat it. Lifestyle changes, look at that right at the top. Lifestyle changes can actually reverse CAD, and this is really important because you're not always told that. Medications, you can treat high cholesterol and high blood pressure. However, this is masking the symptoms. You're not getting rid of it. If you're just taking medicine to lower your numbers, that is not getting rid of the disease or the plaque that is causing the high blood pressure or the high cholesterol to begin with. If you have diabetes, you are at very high risk for CAD. So you can actually reverse type 2 diabetes. Very well known that you can reverse it, and that is all about lifestyle. So that is an important aspect. You can also get into, of course, with the medications, you can get into procedures and surgeries, bypass surgery. We've all heard of coronary bypass surgery or angioplasty. We have heard about that as well. So there are treatments for CAD, but there are ways to prevent it. The best way to handle CAD is not to get it in the first place, because then you're always at risk. And remember, 35 years old, you are at risk. A third of all the people who have coronary artery disease and die from it, it's a third of the people over the age of 35. So really, really important. I'm not going to belabor the point, but it is very important. So if a coronary artery is plugged up or blocked, then you need to definitely go in and have either a bypass surgery, which is bypassing it with another vessel, or you can actually reroute, bypass, so you're bypassing that artery to another part of the heart. And you can go up to 4 bypasses or a quadruple bypass surgery, and we've all heard of that before. An angioplasty, what you may do is go through and basically do what's called a balloon angioplasty, and you will inflate it and then pull it back through to try and open up that artery. You may put in a stent, and what that does is it keeps that artery open. So we're trying to prevent it from closing. So that's an example of an occluded artery and bypass surgery. So best defense against heart disease, don't get it.